Welcome to your cataract and intraocular lens explanation. During this video, we will discuss with you what happens prior to surgery, what happens during surgery, and what you need to know about the aftercare. We will also discuss with you the different lens options available, as well as possible complications.
Vision is a result of the interaction between different parts of the eye and the brain. The quality of vision depends to a high extent on the performance of the natural lens, also called a crystalline lens. This transparent and flexible body is located in the capsular bag behind the iris and is held in position by zonular fibers. In a healthy eye, a clear and bright image can be seen when the light rays pass unhindered through the crystalline lens and focus directly on the retina at the back of the eye. With age, the crystalline lens becomes thicker and less transparent, preventing light from passing through. This clouding of the crystalline lens, called a cataract, leads to a gradual deterioration and, if untreated, to a complete loss of vision. The only effective way to treat cataract is to remove the clouded natural lens and replace it with a clear implant, a so-called intraocular lens, IOL. Cataract surgery is one of the safest and most common surgical procedures worldwide, performed generally on an outpatient basis. The surgery is carried out in the anterior part of the eye that consists of the sclera, cornea, iris, and the crystalline lens. The surgical procedure normally takes between 15 to 30 minutes and is pain-free. In general, local anesthesia is used. The most common form are eye drops applied directly to the eye prior to the surgery. First, the surgeon makes a main incision of about 2 millimeters at the junction between the cornea and sclera. The intraocular lens will be inserted through this incision. Then 1 or 2 additional microincisions are made to enable the manipulation with surgical instruments. Next, the surgeon applies a jelly-like transparent substance called ophthalmic viscosurgical device, OVD, inside the interior chamber. This substance protects the internal structures of the eye and creates space for the surgeon to manipulate with the surgical tools. Then, the surgeon carefully opens the capsular bag where the lens is located and creates a round, continuous opening of approximately 5.5 millimeters. This opening allows removal of the cataract lens without removing the capsular bag. Using an ultrasound probe, the cloudy lens is broken down and gently removed via suction, leaving a clear capsular bag. The red color that can be seen after the removal of the cataract lens is a result of the reddish-orange reflection of light from the eye's retina. Finally, the clear artificial lens is implanted using an injector. The intraocular lens unfolds gently into the capsular bag, replacing the removed natural lens. The implanted intraocular lens stays fixated and centered in the eye and is neither visible nor perceptible. The incisions are self-sealing. The IOL provides the main functions of the natural, healthy lens, enabling the patient to see clearly again at one or more distances. Modern IOLs, such as trifocal lenses, provide good vision at near, intermediate, and far distances, giving patients a high chance of no longer requiring eyeglasses.
Of the video, I will explain the different lens options that are available to you during your cataract surgery. During your cataract assessment consultation, we will perform a number of tests and measurements of your eyes. This information is used in specialized formulas to calculate the optimal power of the intraocular lens that will be used during your lens replacement procedure. Not so long ago, we did not have much of a choice when it came to cataract surgery. When the cataract was removed, a monofocal lens was implanted, and most people were still totally dependent on glasses for distance and near vision post-operatively. Nowadays, there are a number of options available to try and make the patient less dependent on glasses. It is important to remember that there is no intraocular lens option that can guarantee perfect vision under all circumstances. Even the premium lenses have limitations and side effects, which we will discuss now. If you suffer from any pre-existing eye conditions, such as macular degeneration, diabetic retinopathy, or advanced glaucoma, you may not be a suitable candidate for a premium intraocular lens. Let's first talk about monofocal intraocular lenses. These lenses correct one focal distance and are mostly used to fully correct your distance vision so that you are less dependent on glasses for driving and watching TV. If you want to see anything closer, like reading, working on the computer or laptop, looking at your cell phone, then you will always need to put glasses on. Another way to use a monofocal lens is to do monovision, where one eye is corrected for distance vision and the other eye for intermediate vision. This will make you less dependent on glasses for intermediate vision, like working on your computer, but you will still need to wear readers for close-up work. Group of lenses are multifocal lenses. Multifocal lens implants are a good option for people who want to be less dependent on glasses altogether, for those who do not like wearing reading glasses. This lens is designed with several concentric circles, providing multiple focal points, thus allowing for distance, intermediate, and near vision with each eye. Because of the circular design, you don't have to adjust your head position or aim through a specific part of the lens like you would have to do with multifocal spectacles. One can read in any position, including looking upwards and to the sides. The lens does, however, have a sweet spot, which is set for about 35 to 40 centimeters. If you have to do something like threading a needle, or if you have a certain hobby that requires a very close working distance, like jewelry making, you will still need to wear a spectacle with some extra magnification. So the big advantage of a multifocal lens is that it can potentially make you independent of glasses for the most part of your day. It does, however, come with some potential side effects.
Firstly, halos at night when poor light conditions. You should expect to see halos post-operatively, especially during the first couple of months after your surgery. This is normal. These halos are caused by light falling onto the concentric circles of the lens design through a dilated pupil in poor light. You will see a clear light source, like when looking at a traffic light, with one or more dull rings or halos around it. Dysphotopsia, often described as arcs of light in the peripheral vision, streaks or starburst, are also potential side effects of a multifocal implant. Most people will experience increased light sensitivity after cataract surgery, so have some sunglasses ready to wear post-operatively should you experience increased light sensitivity. You will also experience some reduced contrast sensitivity, which means that you will need good light to read well. There will also be some slight adjustments in your color perception, and most people report that things look more like a cool bluer white than warm white. But because of neural adaptation, these side effects are usually temporary, and the majority of people will not be aware of them after a few months. For people who choose multifocal intraocular lenses, the advantage of being independent of reading glasses far outweighs the occasional mentioned side effects. Medical aids consider multifocal lens implants a luxury and therefore will not cover the full cost of the lenses. They will only pay as much as they would for a monofocal lens, and the balance will be out of your own pocket. The last group of lenses are EDOF lenses, which is short for Enhanced Depth of Focus lenses. They are also premium intraocular lenses. They are not multifocal lenses, but they offer more depth of focus than monofocal lenses. EDOF lenses provide a single elongated focal point rather than multiple focal points to enhance depth of focus. These lenses can be used in two ways. One can aim to correct both eyes for distance vision and then also have some improved intermediate vision without the need for glasses. In this case, one will still need to wear reading glasses for any close-up work. Alternatively, and this is how the lens is used most often, the dominant eye can be corrected for distance vision, also providing intermediate vision, while the non-dominant eye can be corrected for intermediate vision, also providing some near vision. Creating this slight offset between the two eyes aims to make one less dependent on glasses, but not completely independent of reading glasses. One is usually not aware of this slight difference between the two eyes, except if you compare the two. The advantage of this lens is that it does not have the concentric circles and therefore have significantly less halos. This would therefore be a good option for people who drive a lot at night or who are worried about how the halos will affect them. It would also be a good option for people who are used to monovision with contact lenses. One should, however, expect to have to wear reading glasses at least sometimes, if not all the time. Medical aids also consider these lenses a luxury item and will also not cover the cost of the lenses in full, as with the multifocal lens implants. If you have a significant degree of corneal astigmatism, this will need to be corrected with a toric lens. All three of the options explained above can come in a toric version. After we have done all your preoperative tests, we will inform you if you need a toric lens. In order to optimize your post-operative refractive result, it is important for us to know if you've had any previous refractive eye surgery like Lasik, PRK, or radial keratotomy. These procedures alter the natural shape and curvature of your corneas and make our formulas slightly less predictable. This means that we may not achieve the intended target. We call this a refractive surprise. Dr. Aleksic might advise against using a premium intraocular lens in these cases, but each case will be considered individually. People with high refractive errors or very steep or very flat corneas also fall into this category and may have a refractive surprise. If we find that you fall into this category, it will be discussed with you in more detail. In cases where we do not achieve the the desired post-operative refractive result, and it is unsatisfactory for both the patient and the surgeon, there are ways to enhance your vision. Firstly, one can wear corrective glasses or contact lenses if and when needed, like for reading very small print or driving at night. A secondary surgical procedure may also be considered. If your corneas are regular and of normal thickness, laser enhancement might be an option. Alternatively, a piggyback lens implant can be used to fine-tune your result. Choosing which intraocular lens to use can be difficult. We are here to guide you, but ultimately only you can decide which option will best suit your lifestyle and address your visual requirements. Please feel free to contact us if you feel the need to discuss your options in more detail.
Before your surgery takes place. Dr. Aleksic does these type of surgeries at the Life Peninsula Eye Hospital in Claremont, as well as at the West Coast Private Hospital in Vredenburg. If you are on a blood thinning medication, we ask patients to stop taking the medication 5 to 10 days prior to surgery, on the condition that your GP or physician is in order with it. What you also need to know is that someone will have to drive you to the clinic and obviously drive back home again. You can plan on being at the hospital for approximately 2 to 3 hours. When you get to the front of the hospital, your name will be on Dr. Aleksic's theatre list together with your authorization number from your medical aid. They will admit you through to a ward where you will meet with the anaesthetist. He's going to measure your blood pressure, ask you a few questions, and then they're going to put a dilating drop into the eye that's going to be operated on. Once the pupil is fully dilated, they will admit you through to the actual theatre. You are not going to change over into hospital clothes. They are going to give you a gown to put on over your own clothes. So we ask patients, dress maybe slightly warmer than usual. If you are not going to have the surgery done under a general anesthetic, you are allowed to eat something light before surgery. In this section, I'm going to explain to you what happens in the actual operating theatre. The operation is usually performed under a local anesthetic given as eye drops or injected around the eye. Sometimes a general anesthetic is used, or your anaesthetist may offer you a sedative to help you relax. If you have a sedative, they will give it to you through a small needle in your arm or the back of your hand. You will be able to ask and answer questions, but you will feel relaxed. Your anaesthetist or surgeon will discuss the options with you. So how is the actual cataract surgery performed? Doctor will make a small 2 mm incision on the side of the eye. Through that 2 mm incision, he will go in with what we call a phacoemulsification machine. That is an ultrasound that he will use to emulsify the current lens that is now the cataract. Through that same 2 mm incision, you will extract the small pieces of cataract. This cataract or lens previously sits in a lens capsule. The lens capsule serves as a structure for the new artificial lens to nest against. It's only possible for doctor to determine the strength of that capsule while doing the surgery. If he discovers that you have a weak spot in your capsule, you will have to use an intraocular lens with 3 arms instead of 2 arms. Now, doctor takes for each and every patient option A, B, C, D in terms of lenses to theatre, so that he won't be in a situation where there is nothing for him to use. He will then revert back to your second option, which will be a lens with 3 arms. If your lens choice was the multifocal lens, we will then not be able to implant the multifocal lens. You will then still use the 3-piece lens, as we refer to it, and that will be in order to correct your distance vision, in which case you will still have to wear reading glasses. But let's assume you have a good, strong capsule, the whole of the cataract is out. These intraocular lenses come pre-loaded in lens injectors. Now, through that same 2mm incision, doctor will inject the new lens. He will unfold it and place it in the correct position. The small 2mm incision will close by itself. Doctor will put an antibiotic drop in, an anti-inflammatory drop in. He'll cover the eye with a clear shield. They'll put you in a wheelchair, take you back to the ward where they will offer you a cup of coffee, tea, and a sandwich. And then we will wait half an hour or so for you to just be all okay before someone can then drive you home. In this section, I'm going to discuss what happens after your surgery. When you get home, we're going to ask you to use your eye drops every 2 hours until you go to bed. You don't have to wake up during the night to put the eye drops in. You will leave the clinic with a clear shield on your eye, and you are allowed to take the eye shield off, put your drops in, put the eye shield back on again, and maybe sleep for the first night or two with the eye shield on. The following morning when you wake up, you can take the eye shield off, you can wash your face, you can have a shower, and then you are only going to use your drops 4 times a day as per the schedule that you will receive. What you must remember is on the day of surgery, when you get home, you might even have double vision. The reason for that is that the anesthetic has not yet worn off your eye muscles. Your eye may even point into a certain direction. The morning when you wake up, your eyes will be straight and you won't have double vision anymore. We will then ask for you to attend a follow-up appointment 1 day to a week at Dr. Aleksic's rooms, either in Vredenburg or in Sea Point. It's very important for us to inform you that it is important to use your drops as prescribed. We really don't want you to get an infection, as there are some eye infections that can be sight-threatening. Also, a few things to note that you should not do after surgery. Don't drive on the day after surgery. Don't do any heavy lifting or strenuous activities for at least 2 weeks. Immediately after surgery, avoid bending over to prevent putting extra pressure on your eye. If at all possible, avoid sneezing or vomiting right after surgery. Take caution when walking after surgery because we don't want you to bump accidentally into a door or a cupboard. To reduce the risk of infection, avoid swimming or using a hot tub during the first 2 weeks. Don't expose your eye to any irritants such as grime, dust, and during the first few weeks after surgery, try to avoid going out in excessive wind. Do not rub your eye after surgery. If you are planning to travel, the surgery won't prevent you from not flying, but Dr. Aleksic does, however, ask all his patients to be in a close vicinity of the practice for at least 2 weeks after surgery in case of an infection that needs treatment.
In this section, I briefly wanted to discuss the frequently asked questions in our estimates, as well as how to get medical aid authorization from your medical aid scheme. Firstly, I just wanted to point to the disclaimer that we attempt to be as accurate as possible. However, we do not warrant that information or other content herein is complete, current, final, or error-free, and that the information will be applicable to all patients. Let's firstly go through our cataract or IOL surgery estimate terms and conditions. So on the left-hand side, we've got a template estimate, which we'll discuss after we've gone through our terms and conditions and frequently asked questions. So firstly, all quotes and estimates are valid for only 30 days. Secondly, all quotes and estimates do not include the hospital and anesthetist fees, and it is the patient's responsibility to pay these accounts separately. Number 3, unless otherwise and explicitly stated as bilateral, all quotes and estimates are per eye, meaning one eye only. Number 4, our practice has a policy whereby all surgery accounts require 100% upfront deposit payment by the patient before any surgery is to take place. Should payment not be made in due time, then your scheduled surgery will automatically be cancelled. Unfortunately, we do not accept medical aid insurance payment guarantees as payment. Number 5, A patient must apply for authorization for their planned procedure prior to surgery. So this is for patients that are on a medical aid scheme. It is important to note that your medical aid scheme will want you to apply for pre-authorization before you are admitted to any hospital. Number 6, it is this patient's responsibility and not that of our practice for the patient to ensure that they, A, have cover for this planned procedure, B, that they have not been placed on any waiting periods with their medical aid scheme, and C, to confirm the rates their scheme will reimburse them. Number 7, your estimate does not include any post-operative eye drops or medicines. That also includes any follow-up fees with the doctor. The second part is mostly for our patients that are on a medical aid scheme and would claim reimbursement. So, number 1, having medical aid scheme cover does not guarantee full cover for your surgery. All patients are advised to confirm cover with their schemes prior to surgery. Number 2, it is important to understand that claims will be reimbursed at your scheme rate and not that of a practice's rate, meaning that which Dr. Aleksic charges and that which your scheme might reimburse you could be different. Number 3, our practice does not A, submit any accounts to a patient's medical aid scheme, B, charge any medical aid scheme rates, and C, have access to your scheme's rates. All patients are to submit their surgery accounts to their schemes themselves. Number 4, authorization or pre-auth. All schemes require pre-authorization for a planned procedure prior to the surgery date, and it will be the patient's responsibility to ensure such authorization is received from their scheme. Number 2, if a surgery date is changed, then a new authorization will have to be confirmed with your scheme, as each authorization number is only valid for the surgery date which you applied for, and it cannot be transferred to another date unless you got confirmation from your scheme. And then 4.3, each surgery date requires authorization. In other words, if a surgery is performed on both eyes, then you would require authorization for both those days, and they will be 2 separate authorization numbers. Number 5, a tax invoice can only be generated once the surgery has taken place and will be emailed to the patient's email address on record, 1 to 2 days after surgery. The patient can then use this tax invoice to claim reimbursement from the medical aid scheme. Kindly note that medical aid schemes shall not reimburse you on any estimate. Medical aid schemes require a tax invoice. Number 6, gap cover does not cover materials used such as the intraocular lens, meaning once we get to discuss the estimates on the side, on the left-hand side, I would explain that there are 4-digit codes such as these, which we call procedure codes. Then there are codes starting with 0201. These are what we call materials. These are materials that the doctor uses in the theater and which is supplied by the doctor, not the hospital. Now, gap cover does not cover the materials used in a theater. They only cover procedures. Okay, number 7, patients will have a shortfall on the intraocular lens. In other words, the medical aid will not cover your lens choice in full. So as discussed by Joe, Rianda, and all the other assistants from Dr. Aleksic, there are different lens options. Each lens option has a different price attached to it. The medical aids all generally only cover a certain amount towards the lens. If there's any shortfall, it would be your shortfall. Good. Number 8, we are considered a non-network practitioner or not a designated service provider, or commonly known as a non-DSP of your plan, which will result in a shortfall on your account, meaning that the rates Dr. Aleksic or this practice charges is not the same as what your medical aid might reimburse you. Voluntary use of a non-DSP will result in shortfalls for both provider and hospital claims. You should please contact your scheme to confirm the hospital is in your scheme's network. These are for patients that have limitations on hospitals which they could use. For example, Discovery as a medical aid scheme might have Cape Town Mediclinic as a designated network hospital, but not Life Vincent Pallotti Hospital. So it's important that you check that the hospital that Dr. Aleksic uses for his surgeries is in your scheme's network. Number 9, we advise all patients to submit their estimates or quotes, including the anesthetist's quote, to their medical aid scheme to confirm the rates at which their scheme will reimburse them. Number 10, in the unlikely event that same day or bilateral both eye surgery is performed, then the patient is to understand that their medical aid scheme will A, not pay for procedures code 3202 and 3196, and that B, they will have a larger shortfall on the account. So if we go back to the left-hand side, that is codes 3202 and codes 3196. Number 11, Some medical aid schemes may not reimburse the patient for code 0010 or 2802, which is a local anesthetic or nerve block. This code is billed to the patient as the surgeon performs a sub-tenon block local anesthesia injection during this surgery. So that is on the example on the left-hand side, code 2802. And lastly, number 12, any queries related to medical aid schemes should kindly be directed to your medical aid and not to our practice. We do not liaise or work for the medical aid schemes. Lastly, hospital and anaesthetist accounts. Number 1, all uncomplicated cataract or intraocular lens surgeries will have 3 accounts. That is, number 1, the surgeon's fee, which is, as per the left-hand side, Dr. Zoran Aleksic's fee. Number 2, the hospital fee. This is the hospital where your surgery will be performed. And number 3, the anaesthetist's fee. So 3 accounts. Number 2, the hospital will submit their invoice to your medical aid scheme for payment. Should you have medical aid, depending on your scheme plan, you might have a shortfall or co-payment due on your hospital account. You are to please confirm with your scheme if the hospital is in your scheme's network. Number 3, for queries related to the hospital fees or for a quote, please contact these healthcare providers directly. In other words, if you require a quote from the hospital, Lisa or our accounts desk can assist you with a contact and get this quote or estimate for you. Number 4, for any queries related to the anaesthetist's fees or for a quote, please contact their office directly. It's important to understand that our practice is a separate entity from the hospital and anaesthetist, and therefore we cannot quote on their rates. Number 5, please note that there will be an anaesthetist fee for all surgery, irrespective of whether you are undergoing general anesthesia or local anesthesia. It is a requirement that the anaesthetist be available for all surgeries performed in the theatre. Number 6, our practice does not work with the accounts department of both the anaesthetist and hospital, and patients are kindly requested to contact these entities themselves. As mentioned earlier, our accounts desk can assist in getting an estimate from the anaesthetist or hospital on our patient's behalf or provide their contact details. Now, let's go over to the left-hand side. This is a template of a quote for a dummy patient going for surgery. And the reason we created this quote is just to show you certain codes on the estimate, which if you are a medical aid patient or you have medical aid cover and you require authorization from them, these would be the codes that the medical aid will ask you for when you phone them to get this pre-auth. So firstly, the medical aid will ask you, when is the treatment date? So the treatment date on the estimate might not be the actual treatment date you are going for. So you can just give them this planned date. So for example, if you're going on Tuesday, the 31st of May, you can tell them that the expected treatment date or the surgery date is on Tuesday, the 31st of May. Secondly, they will ask you, where would the surgery be performed? And underneath the quote would be the hospital. For example, in this estimate, it says service center is Life Peninsula Eye Hospital, and they might ask you for the entity's number. So this is the registration number of the hospital. So it's the 057 number on the side. They might also ask you who is the attending provider or treatment or doctor or surgeon. So this is also on the quote. It is Dr. in this instance, Dr. Aleksic, and that is his MP or Health Professions Council number. So they will ask you for that number over there. If they ask you for the ICD-10 code or the diagnosis code, you would see that each line has a code. So it's ICD-10. So you can give that ICD-10 or diagnosis code to your medical aid scheme. In this instance, it's Z13.5, but this will differ for every single patient. Now, if your medical aid scheme asks for a procedure code, this is this left-hand column over here on this side where it says codes. Those are procedure codes, and this is the description of the code. But in this instance, they'll only ask for the code. So you can give them these codes on this left-hand column. Your quote might look different to this one. This is just a dummy quote. As earlier mentioned, these numbers starting with a 3 and a 2 over on the left-hand side, these are procedure codes. These are what we would call hand codes. So this is the doctor performing a surgery, or this is a test, for example. Any code starting with 0 to 01, these are what we would call material codes. So these are actual materials being used in the theater, but which are supplied by the surgeon himself and not the hospital. In this instance, just because this is a dummy quote, we named them material 1, 2, and 3. So why I included this on this dummy quote is because your quote might look different, but the lens, for example, would be included under the 0201 code, and your medical aid will ask for the NAPI code of that material. So this, you'll see it in brackets, it'll say NAPI with a long digit in the brackets. Of course, this is a dummy quote, so everything's 0, but they'll also ask you for the cost of this lens.
In our final section, what we need to know from you before surgery takes place. Please inform us of any previous eye surgeries. We need to know about any medications you take, especially blood thinning or prostate medications. If you are allergic to any medications, if you suffer from claustrophobia, if you believe you cannot lie still in theatre for surgery under local anesthetic. Please note, you need to take your eye drops to theatre. You will be provided with a prescription for 3 drops, an antibiotic, and 2 anti-inflammatory eye drops. In-room follow-ups are not included in the surgery fee. The following complications can occur 1 to 7 days after surgery. Infection may occur. Most infections happen 2 to 7 days after surgery. If your eye becomes red and painful and your vision becomes blurred, please let us know straight away. Something which is most prevalent in the first evening post-surgery is what we call exposure keratopathy. This is dryness caused to the cornea by incomplete or inadequate eyelid closure. Light sensitivity is common after cataract surgeries, especially among patients with light-colored blue or green irises. This settles down in a few weeks during the recovery period after cataract surgery as the brain adapts to the new normal level of light intensity. Should you experience poor vision and light sensitivity with a painful red eye within the first 2 weeks after surgery, then please contact us to exclude the possibility of an eye infection. The following complications can occur from 1 month after the surgery. Cystoid macular edema, or CME, can occur within 4 to 6 weeks after surgery. This is when there is swelling of the area of the retina responsible for visual sharpness, causing blurred vision. The swelling usually settles, but you may need an anti-inflammatory eye drop or medication to treat this. If you notice gradual worsening in your vision or blurred vision a few months or years after surgery, this could be what we call clouding of the lens, or PCO. This can be treated with a very simple laser procedure called YAG capsulotomy. It is important to note, although cataract or lens surgery is very safe and predictable, it is not without risks and no surgeon can 100% guarantee perfect results. Refractive surprises can be found following cataract surgery and refractive lens exchange. Accurate biometric analysis selection and calculations of the adequate intraocular lens and modern techniques for cataract surgery all contribute to achieving the goal of cataract surgery as a refractive procedure with no refractive error or ametropia. However, in spite of all these advances, residual refractive error still occasionally occurs after cataract surgery, and it must be noted that the surgeon cannot predict the visual outcome of his operation for every single person. This could be treated with a spectacle, laser correction, or a correction that we call a piggyback lens. A cataract is a common problem where the natural lens of your eye becomes cloudy. If your vision is getting worse and affecting your daily activities, cataract surgery should improve your vision. But generally speaking, the surgery is not considered an emergency and you are welcome to postpone or cancel your surgery at any time. This type of surgery is usually safe and effective, but complications can happen. You need to know about them to help you to make an informed decision about surgery. Knowing about these complications will also help to detect and treat any problems early. Therefore, we ask you that you read the information provided to you. Please ask your surgeon or doctor for more information about the risks that are specific to you or if there is anything you do not understand. This video is intended for information purposes only and should not replace advice that our relevant healthcare team would give you that would be specific to you.